Well, good afternoon and welcome to this talk, A Smart Healthcare Data Analysis System, What Might It Look Like? Our speaker today is Professor Ponnambalam, affectionately known as Pano here, of the Department of Systems Design Engineering. He's a member of the Institute and of the Biotechnology and Health Engineering Center called BHEC here in the Faculty of Engineering. His area of interest is modeling and design of large-scale systems under uncertainty. And he's working, particularly in this project, with his collaborators in applied health sciences on the use of data mining for improving healthcare delivery. So, Pano, welcome.
Good afternoon. Well, just a little bit of background in terms of my work so that you see where I'm going in the talk. So my background, of course, is first engineering. Which means designing things, and the second one is I'm interested in modeling and analysis of data. Of course, lots of people fall in this category. Of course, in the modern days, now we have so much data, so we're trying to figure out how to do this more efficiently, and data mining is one name that might come to your mind. So I'm also working in the use of data mining for what one might call knowledge discovery, which is the sort of the big umbrella under which we're all working, that is trying to find information or knowledge from simply even numbers or not even numbers, some information. Okay, and of course most of the science and engineering obviously using knowledge that came from such kind of studies. Could have been at the laboratory level or at the field level or simply at the conceptual level or theoretical level. Okay, so in that sense, what I'm doing here is basically following that kind of idea that I have observations, and which is information, whether I can actually find some sense out of it. Okay. So I also am curious, or still very much wondering about as a sort of public, lots of data being collected. The question is, how is it being used? Okay, I mean, some of the time we are suspicious about the collection of data. Some of the time we see results of it, and so we just have to wonder how one can use this data. Of course, each stakeholder might have a different point of view. Okay. So basically, my outline is to talk about what we call electronic health record, or simply data that is concerning one's health in some form. And the two forms I'm looking at is the smart card form, which is basically like a credit card, but you have it on yourself. And the other one is the electronic health record, which is usually kept in some central web server by an organization. Okay, so I'm going to look at these two. Although from my own knowledge, I think smart card is not, as far as I know, is prevalent in Canada or not supported, whereas electronic health record is. Whereas in the US and also in many places in Europe, smart card is already there. Okay, so I mean they're in a sense complementary, I would say. Okay, and I would, in a sense, electronic health record and smart card have their advantages, disadvantage, and I am not going to talk about that, but rather how to use the information that's in them. Okay, and more importantly, if you look at smart card, of course, it has individuals' information, and usually electronic health record means that somebody keeps it in a web server, so you have basically tons of information of many people. Okay, so my question is more to do with how do we use all that data. And of course, I want to talk more from my own experience, which is data that we have from mental health institutions in Ontario. Okay, so that's the one I'm going to use it as my case study, and then probably jump to some kind of very general conclusions from that. Okay, just good and bad. Okay. Smart health card, of course, just a brief description. I think many of you know that it is not like a credit card because it has actually some kind of a microprocessor. So it it's not simply something you can read off. So you need to be authenticated to read the information from it. So it's, for that reason, is at least far more secure. And of course, just like credit card, one is probably expected to carry it on yourself. So that's, in that sense, is similar. And on the other hand, it can be easily connected to a web server through the card reader. Like not directly, but you can, whenever you go through the card reader, it's possible to make the information go through the web and come back to it. Okay, so it's not impossible. What kind of data that it has? Because it is meant for a person, like individual, first, of course, it says about itself, the device data. Then you have, who's the carrier, like basically who's the user in terms of his or her ID and other things like who's the closest relative and addresses and so on. Then you have what we have system data, which is, I would say, mostly to do with funding, like insurance kind of information. And lastly, the important one that I'm interested in is clinical data or medical data that's about the person's health, basically. Okay, and again, there is no specific standard that one says should be followed to put it in. I mean, depends on which organization is supporting. So depending on that, this data will have some variance. On the other hand, Canada is going, in a way, a much bigger way to electronic health record, and it's defined as has a health record of an individual that is accessible online from many separate interoperable automated systems within an electronic network. So the most important idea is that it's online, so that means it's in some kind of a network, and it is a simple definition, but what the organizations are trying to do is, for example, here Canadian Health Informatics, which is giving it a bit more specific meaning. So their own vision is, well, I want to give high quality, sustainable, and effective Canadian healthcare system supported by infrastructure that provides residents of Canada and their healthcare providers with timely, appropriate, and secure access to the right information. So it's basically similar idea being implemented by Canadian Health Informatics or supported. And most important, they say in the end, is respect for privacy is fundamental to the vision, which is, of course, as an individual, we all want to make sure that this happens. But as a researcher, I find this gives us a lot of headache because if first, people don't share the data with you, which means you can't do anything. And second, if you do get the data, you have to be extremely careful with it, assuming there is open, there's information that should not have been publicly available. Okay. Of course, this is where I think there's more work needs to be done. I mean, there is possibility to provide data without identifying the actual client or the patient, but it's still not there, at least in the study we have done. But all this is, of course, is basically about data. But more importantly, we want to look at the much bigger framework, which is the so-called e-health. Okay, of course, I'm assuming it's electronic here, but it's a much bigger definition, and of course, it involves institutions, home care, and primary care. And I just made it a little bit more specific from my point of view. So, an institution setup, anything starting from simply for administrative use, like, for now, many of the health cards are like that, to a more sophisticated level of, teleconsultation, telemedicine, and so on. So all that is of interest for institution. In the home care case, most importantly, probably monitoring and even some diagnosis is what we're looking at in terms of the use of e-health. And then, of course, primary care starts from basically keeping patient record in an easy-to-access manner to allowing for electronic prescription service and so on. Okay, so these are all from some kind of benefits that we hope to get from e-health. And in terms of my own vision is that, of course, what I think we want to do for a patient is continuous monitoring and guidance for better health and preventive care. Okay, and I will explain a little bit more on that later. Professional practice, of course, as a practitioner, you want to keep improving your practices, so improving best practice guidelines and rules. And of course, this is probably from the sense of College of Physicians and Surgeons, so they want to improve their own professional service. And then in terms of governance, we want, of course, improve all sorts of regional, provincial, national, and global healthcare, health governance. Because with globalization, this is not anymore theory. I mean, you probably have heard of radiology reports being sent from the US to other countries and be read there and results brought back. So it's basically it's a global issue. Okay, so data, when we say data here, it's basically could be anywhere, any point of the world. Okay, so this is a general framework for using electronic methods for providing healthcare. Okay. Well, when I was invited to give a talk, first thing, of course, you want to know is, why should I give this, and who else had done it? I mean, am I going to keep doing the same thing other people have done? So I looked at it. I mean, superficially, they may look like heavy overlap in some cases, less overlap in other cases, but it starts from at least just 1 year of seminars here, starting from very important issue of wait time information, which is a big issue in Canada now, providing basically wait times for all kind of surgeries and so on for public, to drowning in data. So basically, the other end, if you have too much data, and what do we do with it? That kind of question. And from my understanding, he has spent more time describing basically how to keep this data in an easy to access form. So it's more from a database kind of view. Then you've gone to the bottom where, how can physicians be involved in it? Okay, so there's wide range of talks just in 1 year alone. I mean, not including mine. So of course, the first question is, why do we need yet another e-health seminar now? I mean, that's the first question people might have, especially if you looked at the website. That this is a seminar that's easily available to the public because of the slides available, the webcast, and so on. So I don't want to make it look like I'm just doing yet another e-health seminar. Fortunately, I feel that I have something, at least some part of my lectures are unique. That's only because my experience from doing this health study with mental health data. Okay, so without that, I don't think I can stake that claim. And of course, that has given me, again, a much more general vision of what, at least as a person, individual, what we can do in terms of using this data, and as a scientist or engineer, and so on. Okay, so that's where I am here now, to sort of give my view of what is possible and what must be done. Just like anything new, this is 4 years old, so hopefully things are getting better. Initial reactions to e-health, just looking at the electronic patient record, that's what I'm looking at. You can see about half the people are not too happy about it, and half are happy about it. So there's still a lot of people who need to be convinced this is the way to go. Okay. I'm again hoping that some other thing we are doing is going to convince them that it's worth doing. Okay. Because first, anything new will have a problem in the beginning for adaptation, and second, sometimes new can actually be not necessarily good. Good could be defined in many ways. Okay, so we of course always want to be careful about that. Okay, so there's nothing wrong in trying to convince oneself that there is some use from having electronic health records. Okay, and there's always a possibility for things to have some disadvantages. Of course, we should also have a look at it if we can. Okay. So on the positive side, as you probably know, that North America is one of the sort of developed regions where e-record or health record, electronic health records are not widely prevalent compared to some other countries like in Europe, or Australia, for example. So for this reason, there's still a big push first to make available electronic health records. Okay, there's still a long way to go. But still, it seems like U.S. government, which is a very big player in this, will basically say that this is how it's going to be in 10 years or less. Okay, so we will have electronic health record. Whether maybe it's a slow process, faster, we don't know, but it's going to be there. Okay, so why not plan for it? Right? Of course, they say basically from the point of view of removing paper records and the benefits coming from that. Okay, so I am going a bit hopefully further, not as far as say telesurgery and so on, but I'm just going only based on that data. What can we gain? Okay, so that's how I'm going to look at it. Okay? So I'm assuming I can show some benefits which probably still need to be computed and calculated and shown. Okay. Well, in terms of electronic health record, at least I'm now going from the Canadian point of view. What are the objectives for having that? Because you don't want to just start something without putting some vision on it. Well, sure, better prescribing practices seems to be the first easy step to show to the public that there is a benefit in having this, because obviously nobody wants to have the wrong medicine, and they want to have it quickly and reliably and so on. So that's better prescribing practices is where it's starting. The next big public issue, reduced waiting times. I don't know how we can reduce the waiting time just by having electronic record, but for sure you can have better management of it. Unless, of course, somehow that helps you make the resources more optimally allocatable, so then you can probably hope to have reduced waiting times as well. Okay, so if you find hospital beds free and it can be a possible place to send your patient, and it's available to you as a family practitioner, so then okay, you can use that, or specialized resources like surgeons and so on. If they have time, you can find easily, then you can send your patient there, then it's okay. It reduces waiting time. Okay, so I'm assuming that that's how they're saying it can be reducing waiting time. But on the other hand, at least publicly, it's easier to find what the waiting times are if you have more electronic information. Then, of course, improved access in remote communities is a big issue in Canada, since it's a very large country with a lot of sparsely populated, far away remote communities. So, makes sense to have a cheaper way and faster way to access information. And my own interest, complete and accurate clinical data for diagnosis and treatment. That's going to be my major focus in this talk. And lastly, of course, less administrative burden and more time with patients. I mean, assuming that that's well designed, that the physicians actually take less time recording things, and which means get more help from the recorded information, somehow allows them to spend more time with the patient. Okay, I mean, this is maybe it's a benefit, but it's not like very easy to get it unless many things are designed for it. Okay. In fact, it could be the other way. I mean, physicians could be wasting a lot of time on it, okay, and need to be trained and so on. Okay. Well, since I said my own interest is on the clinical data and somehow use it for diagnosis and treatment, which is, of course, a difficult subject, but since I like it, I'm just looking at it. One other thing I was looking at is what's out there now for the physicians or anybody. There's a lot of information. I've just choose some 3 of them. There are supposedly diagnostic tools available. Of course, some of them are more than diagnosis, is for treatment. And of course, sometimes you always wonder, is tool or a toy? And also for legal reasons, probably most of them will give a sort of disclaimer because they don't expect everybody to use it without having been trained to use it. Okay, I mean, it's not meant for simply a public use. I went and looked at some of these sites. You can give some idea of this. So there's one of the physician's own site. He has quite a bit of suggestions of what are the other sites to look at. Okay, so I will show you a little bit of examples later. Then we have this one. It's a little different in the sense, if you look at it, the idea is how physicians can connect with the patients so in order so that they can take their medications on time and some kind of basic monitoring and treatment through the computer. Okay, so it's a next level where the physicians meet the patients. And then this is a fairly comprehensive website where there's lots of information on various software tools available. Of course, it's all meant to be reference material. After all, doctors have to consult, or even specialists have to consult some kind of material, whether it's books or websites and so on. So this is one other way to consult or use it as a reference, but still, just like anything else, these are all tools. And I will discover one of them or a few of them in some detail later. Okay. So my own interest is more in this area, but if you think, how do we make use of that? This is one of the first one, one of the popular one maybe now, and it's supported by a fairly big organization, McGraw-Hill Incorporated, and it is a freeware right now, and it is supposed to be fairly comprehensive because it has 1,000 or so, diseases or things that you can diagnose, and most of these tools are available for palm tops, almost all of them, I would say. These are little devices, which some like, some hate. But anyway, this is what most of them are available. And I myself don't use this tool, so what you can do is you can sort of simulate that in a PC. So that's what I have, and I'll just show examples like this. So this is how it might look like. This is just like a palm top, and you have things like this, and you can say, I want to look at what's the risk of breast cancer for a certain type of patient, and you can go there. I'm just taking the default data, and you continue. This is more as, a reference tool for anybody, but meant to be for physicians, so they can look at it. Remember, even after you get this, it's the physician who has to make a decision based on this information. Okay, so this is still a very simple tool. Okay, it's not really doing a lot more work, but it's helping you filter out information and organize it and look at it in a quicker way. That's all. Okay, so it's not going to replace anything. Okay. So anyway, so that's one of the popular tools. But how do these come about? Well, mostly from research studies people have done, and they come up with, this is a medical paper. They come up with, for example, here it is for treatment for type 2 diabetes. They go through a certain observation or tests, and based on the information, you come up with some treatment rule at the end. Okay, so it's basically like a rule-based information system. Okay, and if you think of it, lots of things that we do are like that, even whether it's common life situation or professional situation. Okay, so it is not too hard to implement this in a software, but there are a lot of work still needs to be done, because there are issues like whether some of these values should be exactly 7% or should be a bit more vague on that. Okay, so there are new tools that one can apply on this. It could be probabilistic based or it could be fuzzy logic based. So these are the two kind of uncertainties that at least I normally deal with. There's there are one or two other techniques for such uncertainties, but most important today is these two, statistically based or fuzzy logic based. Okay, so they will be able to make this not so crisp. Okay, because that's what probably a human expert makes decision. Even if it's a bit 6 or 8, they may take some guidelines from this. Okay, so that's important still, right? And anyway, that is, some theories can be useful to make it a bit more easier for the specialist to use, but still it's the specialist who at the end uses this information. Okay. Well, just to sort of summarize, modern medicine or healthcare depends on so many tools. It could be electronic monitors of various kind, or laboratory analysis, MRI, bigger tools like MRI or CAT scan. Radiation therapy is full of computational tools and sort of high-tech devices. And then, of course, some robotic devices, whether it's for analysis or for telesurgery. Okay, so there are many tools that are being used. So I'm not doing anything big in the sense I'm just making one more tool. Hopefully, it will be available for people to use, or many people are working on it. That's going to be mostly on software based on some new algorithms and knowledge. So my own interest is how do we get this knowledge? And especially, it's more likely now that if we have electronic health record for a lot of people. Okay, so that might give us some idea of gaining knowledge from this information. Okay? And of course, none of these tools replace the practitioner, whereas a good, well-trained practitioners can make a good use of it to save lives and time. Okay? But a well-designed tool is important. Well, I'm just now going to give us some general idea of what I'm going to talk about, but I'm going to based on my own experience, which is the mental health care data. So the way we provide a system architecture, or we propose a system architecture, is here we have many institutions. So it's at the institution level, not at the individual psychiatrist level, but it's at the institutional level. So we have many facilities. You basically are regulated. I'll talk about the regulation a little later, to take data on these patients. Then, of course, there are procedures you have to follow that you will take to do the treatments and decisions. And, of course, its effect on the patient, which give new data. The whole idea is, of course, to collect from many institutions this data. And then using the data, which includes the decisions and its effects, right, to come up with some kind of knowledge discovery. Okay, and I'll explain to you, I mean, this is not knowledge in a very general sense, but knowledge in a specific sense, meaning answering certain questions that need to be answered for a decision maker in an institutional setup. Okay, so that's the kind of knowledge we're talking about here. Okay. There are a lot of tools, and so we're going to show just a few of them. Well, most of this, we're sort of putting it under this so-called data mining area, which is most important is, of course, we want to clean up the data, because often data are not necessarily very easy to use or without gaps. So as best as we can, we do the transformations of those. The most important, of course, is to figure out some kind of patterns there that will provide us the knowledge. And simply saying data is basically information, knowledge is something like useful inference that we got from the data. Okay, so that's very simple definition. Believe it or not, this is not a complete in the sense of people have completely agreed on this, because there's a lot of debate on this. Okay, so for now, I'm going to assume that simply data is information, knowledge is that it provides some inference from that information. Okay, so that's where I am now. Well, in a very simple example, why simple? Only because I have fewer variables. See, I'm an engineer. Whenever I say simple, doesn't mean the problem is simple. I'm just saying it's a small size problem or fewer variables that I have to play with. Okay, so that's what I mean simple. I mean, obviously, breast cancer is not necessarily simple. But here I have only 7 variables that I'm given and data on that. And I have to come up with conclusion A or B, malignant or benign. So that's how that's all I'm looking at from the data. That's all I can do, as well as I'm asked to do. And I come up with some kind of decision tree that tells me that. Okay. And this is the reason I'm using it, first of all, is because it's only 7 variables I can put in one picture. And second, it's a well-studied data. So I'm just one of the hundreds of others who've studied this. And the results of this study is basically looking at different software and different algorithms, how well they predict the A's and B's, the benign or malignant. This 0R, I will explain again more. It's a very simple method, which is just like something like based on averages kind of thing, right? Which of course has because it's so simple, that's like our baseline. So we should be able to do better than that. Otherwise, we don't have really any good algorithms. So 78% for this problem, and most others are in the 95 and above. Okay, so this is a nice result. That's why everybody uses it. But this is just to show that you could come up with trees like this, and which will have 90s and above accuracy in predicting certain diagnoses. Okay. Now we want to do far more complicated than that. So that's what I'm going to do as a case study. Okay. The case study here is again looking at whether we can get some kind of decision rules or decision trees or interpretable knowledge from large amount of data. Okay, so I will describe the data a little bit and then how we did the study. And the whole idea is based on providing better healthcare delivery, especially in the mental health institutions. Okay. And I have done this study with many colleagues in Waterloo, and the 3 organizations that are associated with this data is Homewood Healthcare Research Institute, which is a mental health institution, Pattern Discovery Systems, which is doing knowledge discovery, and Interi is the organization that provided instruments or say standard forms to collect data. Okay. I'll show a little bit about the data set. So Interi has what they call the minimum data set, and it is an assessment instrument for many residences or institutions, like even home care and so on. So they say this is the smallest number of pieces of information required from each patient. Okay, so everyone must provide or be giving this kind of information for care in these institutions. And this is collected by, of course, professionals, usually I think psychiatric nurses and clinicians. As best one can do. And of course, now because of the regulation that in Ontario, any institution that cares for a mental health patient has to collect this information. We have literally hundreds and thousands of records. In fact, I have only used 4,000 of it. Okay, so I believe some more of this data can be used for probably to develop new algorithms and tools and so on. Okay, so there's still a long way to go. Well, again, this is fortunately is a very well organized information system in the sense that Interi provides standard tools to be available, collected, and it's not only in Canada, there are in many countries now. And these are different situations, like this is home care, this is mental health, and so on. There are many different situations. Of course, a lot of common things, but still specialized to a particular care, like it could be palliative care and so on. Okay, so the good thing is these records are not yet electronically available for all of them, but generally going that direction. However, mental health records that we have are electronically available. Okay. The interesting thing is it has 400 data items per patient record. So compared to 7 I had for the breast cancer, I have actually 455 or something like that. It's a huge number per patient. And not only that, eventually we'll have basically like a time series. Okay, I mean, not necessarily at regular intervals, but it could be like every, whenever they had to be admitted, there is the data taken on this patient. Okay, so you'll have a time series of this 400 or above data point or data attributes for each patient. Okay, and they are of different kind, like personal items, like addresses, names, and so on. But they health service use history, substance use, cognitive state history, nutrition, medications, diagnosis, and so on. Okay, so there's quite a few. I will show only one page of this. So the advantage of this, of course, is it's common language, so it's easy for these different instruments as well to exchange data. It is based on theoretical and conceptual basis, so it's not provided by a non-expert. It's experts who deal among themselves what the best or what is the minimum data set. Okay, and so these are done in a very professional way. And of course, most important is that you can compare, for example, different institutions, how the care is affecting their patients and how the resources are being spent. So it's in many levels. It's not only patient level, but also we can compare how health delivery is taking place. Okay. Well, I just show one page. It's a paper copy of it, but it's many pages like this. So there are 455 questions. But the most important to know is that these are what we call mixed mode data, in the sense that some of them are numbers, some of them are categories, and things like that. So it's not a very simple data. Some of the categories, of course, are simply binary, and some are not, and so on. Okay. And more, one of the thing we had to do, or we wanted to do, was, okay, there was a paper record. How do we make it electronic? Okay. On the one hand, most research is done in making it simply in electronic form, but it's no different from the paper. But we thought that is not taking full advantage of the computers where these forms are placed. So we thought we should have some intelligence behind it. I mean, the simplest, of course, is consistency check of data. And the more complicated is it can even use data mining behind it to see if when you're entering, if the data you're entering makes sense. Okay? Because none of our studies are going to be good if our data is not very good, right? So we want to start from the very beginning to help having the best data we can. Okay? So this is one of the master's thesis that was done here. So it's basically a form, but it's more than just a form. It is more intelligent. Okay? It's essentially the same thing as the one I showed before. Now this in Inter-I, they have a process. The most important, of course, is collect the information, make a decision. I'll talk about decision a little later, how we can help there. Then they have their own care plan based on whatever this diagnosis is done. Then implement the care plan, and then of course evaluate it, right? So we are going to mostly concentrate on this decision-making process, okay, using these tools that we have. So the data mining software and that we're going to look at is these 4 kinds. In fact, the common, like many things are, like 3 of them have common things, which is basically what we call decision tree-based algorithms. The reason for using this quite heavily is that unlike, say, the LVQ-PAC, which is also a data mining tool, these decision tree-based are easy to pass on as a knowledge to the practitioner. So it's basically like a tree-based, like the ones we've shown. Whereas something like LVQ-PAC is almost like a black box. So you give the information, I give the output, right? Which, of course, may be useful as a complementary tool, but I think unless we do something more than just a black box, it's not going to be easily accepted by practitioners. They don't want to simply take the information from this tool and apply it, but rather they want to see why that decision was taken, right? So it has to be much more clear, transparent for the user, the analysis of the tool. Okay, so for this reason, we are trying to use as much as possible wherever that the interpretation is more easily available. That's the kind of algorithm we like. Okay. Anyway, so our one process is basically typical computational process in the sense of collecting data, pre-processing, filling missing values, and so on. So the data set we have is for Ontario. There are 4,000 patient records, each record having 455 attributes. And we, well, in the results that I'm showing here, we did a lot of different tests, but the one I'm showing here, we used 3,500 for training the algorithms or making the knowledge discovery, and then 500 for applying that discovery. So the results I'm going to show are from the application of our knowledge on the test cases. Okay? Because that's, for example, this 500 test cases also called out of sample in the sense they are not used when we did the knowledge discovery. Okay? They were not there. So what I want to show here is just answer two of the questions, most important questions. Okay, there are a lot of questions they have. So first one, that long form, at the very end, what they have to do is to say this patient should go to one of these four categories. Okay, acute care or long-term patient, or a forensic patient, or a psychogeriatric patient. So this is one of the sort of diagnosis, if you want, at the very end. Okay, so this is where we started. But once the results were seen, we were asked a more important resource-intensive question. And what is that? Well, as an institution, they would like to know if a patient, either admitted or readmitted, is a threat to himself or herself or a threat to others. Okay? Because these are more expensive patients in terms of resource requirement. They need to put probably more nurses, better rooms, and so on. Okay? So they would like to know when a patient is admitted if this person is likely to have this to fall into this category. Right? It's a very important practical question. First, of course, for the patient, it's good because if they are diagnosed more correctly, they are going to get better treatment and better care. And for an institution, it's also very important because if they don't put enough resources on these patients, they could end up with much bigger trouble at the end. Okay, so at the same time, they can't simply assume that that every patient needs this kind of care and ask for that much money from the government, because here in Canada it's mostly government providing the money, but the institution providing the care. Okay, so the institution take care of their planning and so on, but they have to ask the government for the money, right? So this is a very important practical question for them, and we were, asked to see if that can be predicted, right? And the reason is, if you look at psychiatric literature, and including our own anecdotal evidence based on discussion, is that a specialist would say would not be able to do any better than tossing a coin. Okay, so you could be a specialist. A patient comes, if somebody asks this question, you can toss a coin and say whether he or she is going to be in trouble. Okay, so this is the best one can do based on human knowledge and expertise, right? And of course, the question is, can we improve on it? You can imagine that if any expert asked to take care of 455 attributes for any patient, and not only that, you have thousands of records of such thing. No human being can digest that information and come up with any inference. It's not possible. Okay, at least I don't think so. But on the other hand, a mechanical tool might be able to discover patterns that we would normally miss. Okay, so this is our hope. There's no guarantee, and it may fail in many cases too. Okay, because if there's no information, there's no knowledge to discover, we won't. Okay, so here, this is a very important question. Of course, we want to do some slightly variations on it. For example, if the actual event has taken place, because this is also part of the studies in most psychiatric journals papers, is that what's the probability of future episode given the past, right? And here we did similar, experiment 8 and 9, similar, except that we removed any previous data that showed they had. Okay, so it's a much bigger, much tougher test. Okay. So I will go straight, because of time, I'll go straight to this one. You can see here that depending on the method we use, depending on the experiment, you can have anywhere from 70 to 90% accuracy of predicting correctly the class, okay? Which is, as an engineer, I would say I would like to improve, because I would like 98, 99. But for a practitioner, when I talked to someone who practices this, he was quite amazed that it's even possible. Okay, because remember, they are looking at 50%, and we are looking at 80%, or even 90% in some cases. Okay, so it's a significant improvement for patient care, the institution care. Okay, so a tool which is right now is very basic tool, it's not specifically developed for this problem, can do, probably can provide some help. Okay, so that's our major thing. Now I want to conclude this talk. So that's our specific, experience, and also I hoping to continue to develop tools and use. The question is still 4,000 data. We have hundreds of thousands of data. Because of regulations, this must be developed. This must be collected. So what's the point of collecting data unless we actually use it, right? Because collecting data is not cheap, right? So me, from my own very narrow point of view, I'm only looking at this part. Because there are other people who look at other things, like can we do better resource management and so on, okay? Or can we keep the data in a better way and cheaper way? So those are all issues, okay? But I'm only looking at this particular issue, which is how do I gain knowledge from this data, okay? And of course, the other ones are you can use this also to look at systemic deficiencies and efficiencies, because we are looking at different institutions. So depending on the care and the cases and so on, you can come to some kind of indices that can help them, just like test for Ontario curriculum grade 3 or 6. Okay, I mean, it's only to help the school plan to do better next time around. I mean, it's a continuous process. Okay, and of course, for governance, you want to look at whether you can do better resource management. And of course, last is, as a patient, you would like to get some kind of continuous monitoring, as well as for a practitioner, that might be of some help. Okay. Now, so basically, ideally for the patient, anything like this, collecting data or monitoring, you would expect that to be useful directly. One, of course, is continuous monitoring and guidance for preventive care. I mean, I said, well, one of the worst things we can do is, because we said continuous monitoring, every 5 seconds you can get some shot here saying, don't eat that food, or go run, or getting fat, and so on. I mean, probably we don't want that. So but on the other hand, it can be what we call event-based, so which is basically going to only tell you when you're doing above a certain threshold, okay? And it can be, controlled by you, basically. So that's a continuous health sort of help. Right. On the other hand, for more serious patients, probably continuous monitoring of various things are possible now, and how to use that data is what I'm looking at. Even if you get long series of, blood pressure, how do I use it so that I can give some help to the person as well as the clinician that something must be done. Okay. And for, of course, practitioner. In addition to looking at individual patients, he or she wants to improve their practice, which means protocols are always being redrawn or done. So we have to continuously update their knowledge, diagnostic rules, of course, and any other resource management, whether it's billing of their own services or finding services for the patient. All this can be done with this data. And of course, these last two require knowledge discovery. Okay, it's important to have that, otherwise it's not going to be very useful. And of course, last institutions obviously can use this to do optimal allocation of resources, look at performance indices, and more importantly, new directions. For example, you have data coming from an area, and you find that people are having certain symptoms. Okay, something like this could have prevented large-scale pollution damage health, for example, okay, which is possible in the future, right? And then you direct your resources towards it, okay, find out what the problem is, treat, and so on, okay. So that's kind of our dream, but of course, nothing comes without challenge. We have all these challenges, which includes lots of money at the end, okay. Thank you.
Thank you very much. Thank you. We have a chance now for everybody to ask questions. I'll get you the microphone, and
your talk was a fairly high-level overview of what you're doing, and that's fine. But I have a couple of questions. I gather, you talk about, I guess when you set this up, you have some model in mind that you think will produce the right result. You then, I assume, go in and, as you said, take 3,500 patients and basically train the model by tweaking the parameters of the model to predict what happened to those patients, and then try it on the other 500 to see how well you do. But you already know the results. In effect, the results have been recorded. The results have been recorded in the sense that if this patient was going to do violence to him or herself, you know that.
Yeah, like for example, 4 and 5.
Okay. I just want to make sure I understood how you were developing models. I'm quite interested in this because I'm working with people on the whole idea of diabetes and managing diabetes. And, when you brought up the A1C little model there, for instance, that kind of tweaked my interest a lot.
Yeah. I mean, there's a lot to be done. And so we have not done much more than what we call systems integration, in the sense there are tools available for analysis. There's data. There's certain questions. So we put them all together. But still, if you see our rules, which is because it's 465, the first thing is for our own prediction accuracy that I've shown there, we didn't need more than 165, okay, in the sense that there's redundancy. Okay, there's nothing wrong with it, but it's, it's nice to know that you don't need 455, but you need 165. Okay, that's first part. Second, even 165, if you look at the decision tree, it's extremely hard to understand that, right? I mean, you saw the 7, and imagine 165 variables, right? And they can be repeating, okay? So there's a big question, how do I visualize, in the sense a practitioner can make sense out of it? Still not completed, I mean, there's more to do there, right? So I'm saying that this is more of a challenge. So most of the speakers have looked at data for certain kind of managerial reasons, and I'm looking at it more as a reason for, say, diagnosis and treatment.
Your work is very relevant to my research, so it was very interesting. You had 450 attributes. Did you do some kind of feature prioritization, feature selection, either machine-based feature selection, or did an expert call it and say you only need to look at this set of features? Right,
okay. I mean, we could do both, I mean, which probably is one of the things I would like to do. So if you see validation, need the help of practitioners, and for example, in this case, psychiatrists or specialists in that area must tell us that what are the more important variables, right? Unfortunately, given that they have so little time, they haven't been involved directly in this research yet. But that's one of the future direction we have, okay, which includes like validation. Like even though we chose it by machine, these factors, they still have to agree on it, right? Because it should make some sense for a practitioner, right? And if it doesn't, can we tweak it, like Don was saying, like can we tweak it so that it'll follow their wish as well? I mean, it's a process that I don't want to depend only on machine, and I don't want to depend only on the human. Because if the human could do it, they would have been doing it, right? But unfortunately, there's too much of data here. It's very hard for anybody to digest that and come up with inference. So that's why I feel that there's need from both sides.
So you fed all 450, for each of those classification systems, you fed all 450 variables and trained on 450
and
variables.
Then it can be reduced to 165. This is what I was saying. Like it can be reduced to 165, which are the more important ones. Okay, and I have those 165 to show to a practitioner and see if they agree with that. After all, this 455 was selected by them, not by me. So, but on the other hand, we can't just because of that we can't just go remove all of the rest, because this is for this particular study. Who knows other reasons that we might need some other variables there, right? So that's still, these are the things, directions that I would like to go. What are the questions, what variables is important for that?
Yes, I think you have one of the most, I'm a physician from Germany. I'm not working here.
Microphone.
Oh, okay. And I think you have one of the most difficult fields here, yeah, in the mental health system. And maybe with the blood pressure, for example, no, it's easier,
Yes.
yeah, to come to a certain point. What is the best way to go? Yeah,
Yeah.
but with mental health
Much more.
patients, yeah, and I think you must hold the contact with the physicians all the time, because they are very individual ways. Yeah, well, there you go.
Yeah, well, this is why I like
Yeah.
Susan is here, because
Yeah.
she's going to put the block on us and think
Yes,
hard, right?
I've been working,
Yes.
psychiatric
Yes.
patients, and it's a hard way to go. Yeah, very individual,
Okay.
and step by step you can make your decisions, but never forever.
Yes.
Yeah.
No, I agree, because one other thing, even for other diseases, not necessarily mental health, which is probably the most complicated,
Yes, the most complicated.
yeah, even physically based health, many studies are done in a way that is not necessarily practical. For example, when you go to a doctor, they don't tell you to do all these tests, right? They only do a few. Then based on it, they do another, and so on. But if you look at our data, like, it's often all the data is available at the same time, right? But that's a very, that's not how real world works, right? I mean, obviously, if you've done a biopsy, you're done, right? But nobody is going to biopsy yet, right? Same with mental health, right? Only difference is that in this, it's a fairly unique in a sense. For example, even the non-institutional practitioners in Waterloo or Canada does not have the same 455 questions. So there is this thing. And then second, there are more than one record available for this same patient. Okay, so that's why you can say, well, if they had done something before, whether it affects the future can be gleaned. So I don't say this is the end of it. I mean, we should continues to do. On the other hand, we do have all this data. So my question is, how do we use it? And this is how I find use for it. Okay. And of course, nothing of this is valid unless the practitioners agree on it. Okay, because what's the point?
Hi, my question is just about, you're talking about the health record. Is there some kind of like universal ontology for all of the different kind of health information, or is it all like separated?
Oh, I don't know, Don, you know much about this database than I do.
Oh, sorry. No?
Yeah, Don, better, thank you.
Yes.
Okay. Yeah, that's
Probably one of the greatest challenges we have is the lack of common vocabularies. But if you're interested in that, if you go to the National Library of Medicine website, that's nih.nlm, I think, .org. You'll find something called the UMLS system, Unified Medical Language System. And under that is something called the metathesaurus, as well as the semantic network. And the metathesaurus is a collection of about 600, 700,000 or more terms that are used in the different areas of medicine, and under various coding terminologies, and they're mapped to each other. The semantic network explains the relationship among the vocabulary elements, but it is still a work in progress by a long shot. So that is a big issue. Now in many of the major systems, we don't seem to have that in Canada, there are things called vocabulary servers. Basically an ontology server is what it is. That whenever you use a term, it looks it up in that and gives you a canonical or a standard term that substitutes for the many variants. And if you use this term and I use that term, we're both mapped to the same point in the concept space. So that's basically the way it's done right now, but it's a huge problem. If I could ask you a couple of questions,
Sure.
Probably the most interesting one, I saw a lot of integers in your decision trees. You said you deal with uncertainty. How do you deal with the uncertainty aspects here in the decision levels and variances and so on?
Well, I had this choice of bringing that, because that's my major background. My first suggestion is invite me again. Okay, I can explain much more detail that part of it. How do we combine uncertainty? So the two things, of course, is statistical, which is well known for literally hundreds of years, and the more new field of fuzzy logic based uncertainty analysis is the more newer one. So, the main problem is this, like you have some kind of vagueness around those values. And the more important is that it's not vagueness at one level. So you have vagueness there and the vagueness there and a vagueness there. How do we aggregate all this vagueness together? So that's the big question. Okay. And of course, that cannot be, there's no simple answer because it depends on the data. And that's where we use the training to see what we should, what kind of ranges we should allow, what kind of vague functions we allow. So those are done at the training time. Okay. And then, of course, you use it for the cases that you didn't use for training.
So this does use a fuzzy logic construct behind it?
No, not this. Only one of them uses the neural networks. Okay. We have 4 algorithms there.
See, where I was going with this is that
This LVQ pack uses neural networks, which easily is adjustable with fuzzy logic-based neural networks.
Okay.
But the others are all tree-based.
Right.
Right now, they don't have anything in it, but they are also extendable based on fuzzy logic, like fuzzy Siemens clustering and so on. Okay.
The reason I ask it is that pretty well decision tree types approaches have fallen out of favor in clinical decision making kinds of research. So it's really are you then, in terms of the future of this, looking towards the LVQ pack type thing, or? I
mean, this is like you're saying that it's fallen out of practice, but I have to disagree with that. It is, for example, this is 2006 paper.
No, I know they represent this in clinical protocols.
Yeah.
But in terms of decision-making theory and decision-making approaches, you'll find as what's behind this is, and it's generating these numbers, is not a decision tree kind of analysis.
You could have other methods like support vector machines and so on, right? But finally, when it comes to human being understanding and using, I doubt whether we can do better than this.
No, I think that's why they represent protocols in this method. I think that the really interesting thing that I heard, and from I guess a systems design vantage point, is your intelligent form concept. In other words, as I understand it, and correct me if I'm wrong, as you complete the form, that data is being compared with data in the mind, so to speak, and then if you enter inconsistent information or just stuff that doesn't fit, then it advises you, presumably.
No, again, simple things can be done. For example, you enter say June 31st, and you can say it cannot. That's very simple. On the other hand, you enter certain values for these kind of variables. It's not very easy for a person who's entering to know that. So what it does is it uses the data mining tool behind it to basically say, this seems like inconsistent. Are you sure you want to enter this? That's because it's better to clean up while you're doing it than trying to clean up later. Okay, so that's why we call it intelligent form. I mean, it's a little better than just simple consistency check.
Interesting. Are you aware of the work of Medicalis in the region here related? They're doing something like this related to the completion of order entry forms. And they might be interested in the kind of thing that you're doing. Their objective is to look at the previous behavior of the physicians in order entry, your own and others, and looking at group averages, so that if most people don't do this, you get said, why are you doing this? Most people don't use this. Most people use this test. And that's apparently dramatically affected the test ordering behavior. Yes. So there's good evidence there, too, that this intelligent form thing is an excellent idea and can be applied in other areas as well.
Yes. Because there's no point in going from just paper to electronic and in exactly the same way, because that's not, well, it's not bad, but it's not necessarily the most complete form. Whereas this is, it's using more of the brain behind the computer to help you. That's basically
the final question is, the biggest issue in these systems, because we create thousands of them, is adoption and acceptance. Physicians claim that these systems take them more time to use than doing ordinary order entry or whatever it might be. What is the, what do you see as how that goes forward? How will this diffuse from where a group of researchers use it to where clinicians actually use it in practice? Can you comment on that at all?
Well, this is where we can't do without them, right? Or they can't, there is no validity for this study without their validation, right? On the other hand, it's like a glass cockpit, right? When it came first for flying airplanes, the pilots weren't happy with it. They looked like they didn't have any control over it. But it took a while to figure out a combination of man-machine that has, I would say, is now made it much safer and easier and efficient to fly. Okay. And the same way, we cannot do this in isolation, these kind of studies. But the problem is the physician time is the big question. How we are going to find the time for them to interact with us, and this is still a big question, right? So we are doing as much as possible with consultation, but it's not enough. Okay, so it will be a joint training of our own algorithms method by them and our own knowledge and inference to them. So that's the only way to do it.
I think validating it is one thing. That's where they help you, but it's actually agreeing to use it in practice. And even your protocols there.
No, it's obviously it comes from regulations, right? Nobody voluntarily changes their practice. Okay, for example, that inter-eye data, it is regulated now. Otherwise, I won't have it, right? There's no other way.
So what you're saying is because it's behind the form, it is in fact being used by the people who are doing data entry.
Yes.
The question there is it considered to be of value in clinical practice then? I've also heard with respect to these systems, yes, they are mandated, but they take a huge amount of nursing time. The data is not, it has to be re-recorded in other systems. It's a duplication. And the view is that it's not worth the effort. So that's always the question of clinical utility.
Well, there's always it's a two-sided of a coin in the sense, I agree, I'm sure a lot of them are like that, but that's where as engineers we have to make it more and more user-friendly, easy to use, and actually save time. Right now, of course, in the transition time, I wouldn't claim that, right? Because we are learning as well as developing something for them. So I don't think right now we are saving the time, but the question is down the line, 10, 20 years from now, will we be saving the time? That's the question.
Very interesting. A recent result came out of Reagan Street publications by Zach Cohen is that the clinical protocols are not being followed. So we've got systems that support putting the protocols right in front of the physician, bypassing the effect of education, which was shown to be ineffective. Now the clinical protocols are not being followed.
Yeah.
So it's an interesting battle.
Yeah, and also from a clinician point of view, they say, well, there's hundreds of protocols. How can I do all this in 2 or 5 minutes that I have time for practice, or 20 minutes, right? So this is where we are helping them to have that in their hand more easily than that they have to somehow dig up to get all that done in 20 minutes. Okay, so I'm sure that in the beginning, while it's still in the research stage, we are wasting their time. Okay, maybe, right? But that is hopefully wasted in a way that it will develop further and further better systems, so that in 20 years or 15 years down the line, we actually are saving time.
Interesting. Thank you very much.
Thank you. Thanks.